we are just elated to welcome you all to our second quarterly Screening Navigator Network call. And a few housekeeping things, right as we begin. We want to get to know you all. This is all about networking, but it's hard with such a crowd. So in the chat, if you'll please put your name and your organization and any additional information, if you want to put your title or your role at your organization, please drop that in the chat as well. Also, please, throughout our presentation, feel free to drop questions in the chat because we are going to have time for Q&A at the end. And be sure to drop those in there. And I know you're in for a treat today with our presenters, but at the end, we'll also have time for you to be able to share any struggles you're facing, any ideas or thoughts that are on your mind. So we'll have time for additional discussion after the Q&A and the presentation. But really quickly, before I turn it over to Jenni, I just wanted to let everybody know the purpose of this group. This is your group, and it is for screening navigators to share best practices, barriers, and other thoughts related to lung cancer screening, and to build connections and partnerships to improve lung cancer screening rates and ultimately save lives. So again, we're very excited to be able to connect everyone through this network and to be able to share a great presentation with you today. So with that, I will turn it over to my colleague, Jenni Danai, our Chief Mission Delivery Officer at Lung Cancer Initiative.
Thank you, Paige, and thank you everyone for joining today. And we're going to go ahead and get started. So today we have the team from Levine Cancer Institute, Atrium Health. And if you don't know, they started the first mobile lung cancer screening program there at Levine in Charlotte. And so Darcy Doege is on. And Darcy, if you'll go ahead and unmute and tell us who you have from your team.
Thank you for having us. Again, my name is Darcy Doege. I'm the clinical supervisor for the mobile lung screening program. And
I'm Lauren. I'm one of the nurses with the mobile lung screening program.
I'm Kia. I'm the physician assistant with the mobile lung screening program.
And we have Caroline and Jamie on our team. Caroline is one of our RN program coordinators, and Jamie is our scheduling supervisor.
Awesome. Well, thank you all so much for joining us. I know we have a lot to learn from all of you today. Why don't you go ahead and just tell us from the beginning kind of how you got your lung cancer screening program started?
Yeah, so just to give you the kind of overarching, we let's see, it would go back to 2017 where we started and had our first screening day. 2016 was when the original grant proposal from the Roster-Meyer Squibb Foundation came in. What that covered was the building of our first mobile unit, the screenings for the patients, tobacco cessation and nicotine replacement, and then navigation. And so you want to talk a little bit about it? Yeah, the first mobile unit. Yeah, sorry.
Darcy was initially kind of started the networking process for once we got that initial grant. So she went to all clinics in the surrounding counties, pulmonary clinics, free clinics, federally qualified healthcare clinics, just to promote that we're offering this screening. And so we only accept uninsured. Medicaid, when the first program started, Medicaid didn't cover lung cancer screening. So then they made that change that Medicaid would cover lung cancer screening. However, we went to the system side and said, some people come on and off Medicaid so much that we kind of got the approval that we could keep some of the Medicaid patients if they were already established in our program and they got referred to us. And so we will see some Medicaid patients as well. And then a lot of underinsured patients, as you know, healthcare is expensive. So if they are below poverty line and they have high copays, high deductibles, then we will still screen them. But the large majority, the large majority of our patients are uninsured. That's the whole premise of why we started the mobile unit. Darcy was initially, I have a little technical difficulties here. All right, are we good? Okay, all right, sorry, we're getting the echo. We have two computers up in the same room, so I was getting the echo. Where was I?
You were, sorry. We were talking about the uninsured and the Medicaid. And
yeah, so Darcy initially started, I joined the team probably about a year into us starting the program. At that time, we were in how many counties?
We started in a 9-county footprint, and now we are in 29.
Yes, in North and South Carolina. So we expanded into South Carolina, which was
a big deal.
Yes, a transition for sure. But when yeah, so that was our initial grant that started to screen up to 1,200 patients. Once we hit that 1,200 patient mark, then our grant funding switched to the Levine Foundation. So we are currently now funded by the Levine Foundation to continue our work, which none of it has really, it still provides screening, you know, transportation, food cards, tobacco cessation products for all of our patients that qualify and want tobacco cessation.
And can you, and can you tell me what actually is this mobile screening van? Like, do you actually have a low-dose CT scanner on it?
That is a good question. Maybe we should have said that after the first question. But yes, we have two different trucks. We have one that's like a box truck style, and it has a Samsung Neurologica body tom on it. And then we have a Winnebago style truck that has the same scanner on it. So we deploy both of them. The RV style is better for us for if there's bad weather or it's extremely hot, because there's like working stations throughout. And then we also sometimes offer like prostate screenings on site. So we're doing blood draws. So we like to do like that in one of the compartments inside.
Okay, that is very cool. Okay. Is there anything that you've learned along the process that you wish you had known in the beginning?
A lot. Yeah.
Yeah, I was gonna say there's probably a lot.
Yeah, there's a lot. I mean, yeah, 100%. We when anybody joins our team, we tell them, if you're a type A personality, then that needs to just go out the window, because we really pivot and change on the daily. Not only is our entire program mobile, but our patients are, you know, they're underserved. They're sometimes, you know, harder to get a hold of, harder to track down, harder to get into follow-up care. And also just like starting a mobile unit, a mobile program that had never been done before, is good and bad. I mean, I knew I wasn't going to screw it up, but because how could I? There was no comparison. Yeah, but at the same time, we, you know, with the actual wear and tear on the trucks and what we've learned about driving around with the CT scanner, there is a lot that I wish I would have known in preparation from the beginning. And I think the team could vouch for that, because when they hear like how we ran things at the very beginning, they're like, wow, that was bad. I'm like, yeah. But I mean, not bad for the patients. It just was like processes needed to change, you know, and COVID, of course, changed a lot of that too, for the better for our team, just making sure that we're getting patients what they need.
And what are some of the biggest challenges that you faced getting the program up and running, and really throughout the years too, maybe sustaining it as well, and how you've overcome them?
I would say sustaining wise, you know, there's a lot of turnover in some of our clinics. You know, so it's a constant re-educating clinics, re-educating the new staff, you know, because as all of us on this call know, lung cancer screening is not a top priority for some primary care providers like it is for breast and colon. So just staying present and relevant constantly is something that like we have to do on a regular basis to sustain the program from a sustainability standpoint.
Yeah, and I think that over the years, just constant re-education for not only the providers outside of Atrium, because about 80%, would you say 70 to 80% of our referrals are from outside of the system. And but then re-educating internal folks as to what our mission is. Like why, when the pulmonologists ask, well, why aren't you sending them to Charlotte? Well, we can't send everybody to Charlotte. We're screening in Wilmington and, you know, Kershaw County, South Carolina, and all these crazy places that we're not going to just bring people up to Charlotte for care everywhere we go. So it's constant re-education to shift the focus back to the patient. And not that every provider, you know, doesn't care deeply for their patients, but sometimes they just can't think outside the box, and we're constantly making people think outside the box and feel very uneasy at times, but we're good at that.
Well, and can you tell us how the referral process works and like how you work with the primary care providers?
And here's Jamie.
Sure.
Hi, Jamie.
I'm Jamie. So I handle all of the referrals for the program. So for our Atrium facilities, those come through Epic, they come through internal. For our outside practices, like Darcy said, it is an 80, probably 80% come from external practices. Those come through fax or email. It's kind of like however you can get it to us, so we can take care of the patient. So they'll fax the order over, and then from there, we'll just plug them into whatever is close to them. They may go to one facility, but they live closer to another. And so we just pull up our calendars. We have that set out throughout the whole year, and we figure out what works best for the patient. And then we just coordinate from there. If they need help getting there, then we take it from there. And then for our internal, we just go based off the referral that is sent over. And same process, just whatever's closest to where you live. We want to try to meet you where you're at as much as we can. And now we go to so many counties that we can do that for the most part. So that's kind of how that works.
Well, and so you mentioned your schedule. So the schedule is already planned out for the year, or how does that work? How do you plan that?
Correct.
Yeah, we have the schedule set for the year. We return to each county every 3 months for, you know, obviously for long run fours, or for people that had to cancel, no-showed, you know, they couldn't accommodate. And then we are lucky that we have internal funding for some gas cards, for food cards, for other resources to layer in. A big thing that we do as well, that I think one of your questions you're going to ask me, but I'll just jump ahead, is how our patients, you know, how we're so successful with them returning to us.
Mm-hmm.
And we do a pretty robust assessment of resource needs. So is there food insecurity, housing insecurity, you know, do they have outstanding medical bills they're worried about? That's one reason why they come back to us, is because they know that we're going to ask those questions. Not that their primary care doesn't do it effectively, but we see them, you know, in between their office visits. We also make sure they have primary care set up. You know, a lot of our patients have changing insurance statuses, so they just kind of keep coming back to us. And recently we layered in, like over the last year, we were realizing that a lot of the primary cares weren't letting the providers know their results. And so we're calling ourselves, going over those results. And it has been really good for our team. It's helping our relationships with our patients. Our tobacco cessation program, sorry, I'm kind of like pivoting around here, but our tobacco cessation program that Kia really has like owned and managed, and it is very successful, and is one thing that I think really as we grow that, it's bringing more patients back for follow-up. Do you want to talk a little bit about how that works?
So like we mentioned, we offer tobacco cessation to everyone that wants to participate. No pressure, it's just an offering that we have. If they do decide they want to participate, then I conduct their initial consultation and prescribe their plan of care. So whether that's NRTs, Chantix, Wellbutrin. I will say with the Chantix or Wellbutrin, I do get permission from their primary cares just because, like I said, not everyone's in Atrium, so I don't have access to all their medical records, their medications that they take. So I want that buy-in from the primary care that they're okay with us prescribing it. We have a centralized pharmacy that we use. So all of our prescriptions go to that one pharmacy, and then they mail the prescriptions directly to the patient's house. So it takes that layer of they have to go to the pharmacy and pick up the prescriptions. And then our team calls them every 3 to 4 weeks as check-in touch points. How are you doing? What do we need to change? And we set short-term goals and long-term goals. And we really follow that patient really closely until we get them to where they want to be. Or if they give up, then, you know, they can always re-enroll every single time they see us. We're always available for them. Our quit rate is at about 10%, I believe, the last time we checked. So a pretty good quit rate for definitely the patients that we serve. So it's working really well, and that close connection. And it's no pressure. It's what can we do to help you and support you and your goals.
Yeah, I feel like you guys are so good at supporting the patient as a whole and getting to know all of their needs, which I think is really great. Can you tell me what it's been like kind of getting the word out to primary care providers and how that's been, how they've received it, and how you work with them, especially the ones outside of Atrium?
There's a couple pieces to that, but like Kia had mentioned, a really hard part is clinic turnover and just providers leaving or changing. And in some communities, it's just so much better than others. Like we have one provider up in Morganton. If she goes to a different clinic, she calls us. She lets us know her email address and everything. But then, you know, we could be sending results to a provider that's been gone for 6 months and we had no way of knowing. So that is a very tricky part. We have, do you want to talk about the networking kind of changes that we've made?
Yeah, so recently we started doing more touch points with a lot of our established clinics. We're going back, kind of just showing face again, saying who we are, why we're here, and the next dates that we're going to be in town. I think that this just helps to, again, kind of show face and show that we're around. And it's been proving to be successful for our next go around.
Yes, I think just the constant checking in with the providers, making sure that they're getting the results, especially with our positive patients, calling and letting them know, you know, this is what the nodule conference recommendations are. Do you need us to help you refer the patients? I mean, we do anything from hands off to we'll call and schedule the PET and the pulmonary appointment and the PFTs and take care of it for you. It just depends on what the needs of the clinic are, especially the free clinics that don't have a ton of resource. A lot of times they're like, just run with it. So.
And are you all actually on the bus when it goes around? Like, do the patients meet with you personally?
Yeah. Yeah, when we deploy, we have our Atrium Health mobile medicine, they have a driver, and then we have a CT tech and that is on our team, Taronda Cureton. And then our team kind of tag teams screening. So there will be at least three of us. Then also we have a data coordinator on our team, and he oversees our clinical trial that we have open for accrual for those 40 to 50 years of age that don't fit the USPSTF criteria. So that's the 20-pack year smokers, 40 to 50, and that is regardless of insurance status. So if you guys want more information on that, I can send an email to the group. But as we have said, this is kind of a wide, we have a pretty wide range in North and South Carolina. So if you guys have want to share the word about our study that's open and our program in general, and think that it would be impactful for patients in your areas, then please reach out.
That's great. I'm excited to see what you all learn from that study. That's going to be really helpful.
We hope.
Yeah, I bet it will be though.
Yeah.
Okay, what is one thing or one piece of advice that you all can give to everyone else on the call today about just in general increasing the amount of patients getting screened for lung cancer?
I think that, sorry, I'm really articulating well right now.
No, I was gonna say, I think just building relationships with patients is
Mhm.
helping to bring them back. I know we just started calling patients with results, like Darcy said, and it's helped be a good conversation piece to educate on what's going on, why we're doing this. Even though we don't see anything today, it's really good that we do this annually, and just having that conversation after the fact has helped.
And we also, we have patients that will actually refer like friends and family to us rather than, and so we do accept walk-ups as well. So we have a schedule set for the day, but we accept walk-ups. If they don't have a primary care, I'll write their initial order and do all the stuff that they need. And then we will establish them with a primary care to follow up with. And so we get a lot of like, oh, my, husband, significant other, partner, is there, they qualify, can they get screened today? In the same way with tobacco cessation, we ask, does anybody else in your house smoke? Do they want to be, because, it's better to do it together. And, if they do smoke, do they qualify? And, and we educate that way. If they have insurance, then we're like, we give them information and say, please talk to your primary care about, scheduling this at the hospital. So there's a lot of self-referrals happening as well once the patients get educated.